Greetings. I'd like to welcome everybody to a very brief, focused talk today about a syndrome and a condition that I'm very passionate about, as is my colleague, Dr. Armstrong. My name is Dr. Feyma, Tim Feyma. I'm a neurologist at Gillette Children's in St. Paul, Minnesota. I run the Rett Syndrome Excellence Center of Excellence there. That's given by the International Rett Syndrome Foundation. I also do movement disorders, a little bit of epilepsy, and also intraoperative monitoring. I also am an adjunct professor at the University of Minnesota. Dr. Armstrong, can you introduce yourself, if that's okay?
Sure. I am the medical director of the Rett and Related Disorders Center at Children's Health and work at UT Southwestern as well.
Thank you. We're very excited to be here with you today. So in the next 15 minutes, we'll try to do a very quick yet thorough and succinct review of Rett syndrome overall. It's an area of hot focus nowadays, as there are some therapeutics being developed. So let's start with a brief introduction on Rett syndrome. I always like to start rather large and try to focus in if I can. And so just really speaking in a very high level viewpoint of Rett syndrome overall, it's a condition where we tend to see typical development around until the regression happens around 6 or 18 months. With the regression, there can be loss of speech, loss of hand use. Gait may or may not develop, but if gait does develop, it may become more imbalanced, and typically there's some hand stereotypies that we see as well. After the regression phase, there tends to be stabilization over time, but there can be slow progression over time as kids grow, and certainly there's concerns when they hit adulthood that there is a little bit more progression and regression and sort of increasing difficulty with movement and function overall as in adults. If we really go from more of a really simplistic view, which I just hopefully made a case for, to the diagnostic criteria on the next slide, the overall diagnosis of Rett is clinical based. And so we rely heavily on the clinical criteria from Dr. Newell's paper that he published, I think in 2010 it was. Typically, Rett syndrome patients have a period of regression followed by recovery or stabilization. Classical Rett syndrome needs to have all four criteria, which is partial or complete loss of acquired purposeful hand use, partial or complete loss of spoken language, typically gait abnormalities, including absence of gait, and stereotypic hand movements. If they have all four criteria and they've had a period of regression and they don't have exclusion criteria, which is brain injury or another cause for the unique brain development or delay, or grossly abnormal psychomotor development in the first 6 months of life, like if they're really delayed the first 6 months of life, they never sat, they never crawled, they never rolled, then they have classical Rett syndrome. If they only have two of the main four criteria, they can qualify for atypical Rett syndrome as long as they have 5 of the 11 supportive criteria. And they're listed here on this slide. I won't go all through them in detail. And it's also good to note that many of the classic Rett syndromes have many of the supportive criteria as well, but they typically are mandatory that they have the supportive criteria for diagnosis. This is a change from, with Dr. Newell's paper, from some of the older definitions where we had the preserved speech variant, we had the early seizure variant, but we've sort of streamlined this into classical Rett versus atypical Rett, and we sort of, there's no, I want to make sure that we highlight there's no specific mention of gene mutations. This is a clinical-based syndrome. We have other syndromes like this in neurology, like Dravet syndrome, where you can have an SCOMA mutation in most of the patients, but you can also have Dravet without it. So with Rett, it's a similar very situation where you can have Rett syndrome without the MECP2 gene mutations, we'll talk a little bit more about. And so with that, I want to transition over to Dr. Armstrong. So can you share some information on diagnosing Rett?
Yes, I'm happy to do that. It's worth commenting that it is really, diagnosis is based on clinical criteria, and that the MECP2 pathogenic variant or mutation is not required for diagnosis. And we will always have that arrest of developmental progress, regression of skills, and then a stabilization phase. And you did a great job of reviewing those criteria. So Dr. Tim, could you talk a little bit about multidisciplinary care for patients with Rett syndrome?
Yeah, I'm happy to do that. I think that as with any genetic syndrome, we control a diagnostic criteria, but not every child checks every box. And so oftentimes we use multiple disciplines to help care for the children. And I'm going to highlight that I think the caregivers in the upper left-hand side of the slide need to be enlarged, because I think their presence is so important, because they are the foundational element. But many of these patients do have movement disorders, epilepsy that require neurologists, they sleep disorders as well. Sometimes neurologists deal with that. Sometimes sleep doctors deal with that. And also there's a lot of overlap between developmental pediatricians as well. There is a a lot of indistinct borders, and sometimes providers in different regions handle more or less of the needs as well. And typically, as the girls grow, sometimes they will develop scoliosis or hip dysplasia. So we really watch the back. If it gets over to a 40-degree curve measured with Cobb angles, sometimes we will recommend a correction of the back. GI, because we have a lot of issues with constipation and GI discomfort. And the bedrock too, outside of the medical specialties, is the physical therapy, occupational therapy, speech therapy, both in school and maybe privately as well. Oftentimes, speech therapy also manages some of the augmentative communication devices. But I think I've said enough there, so I can pass the microphone back to you. Sorry.
No, I think that this slide is a lovely place to talk about how much interplay there are between those different specialties, and how hearing from families and teachers and some of the therapists, these kind of three main domains keep rising to the top, in that reflux, feeding, constipation kind of falls in one bucket. Expressive communication, both low tech, finding a way to kind of give an affirmative and a negative response, as well as high tech with eye gaze devices, as you were starting to talk about. Um, and then sleep, both falling asleep and staying asleep, all are really prominent concerns that all play together, right? Constipation, when girls and individuals with Rett of both genders are constipated, they get irritated, there's more bruxism, they're less likely to feel regulated and calm and able to interact with the speech therapist who's trying to teach the individual how to interact with their eye gaze device. And when they're able to express their needs, they're more calm, they're less likely to be agitated. And when their sleep is high quality, both the caregiver and the individual are more relaxed and rejuvenated and ready to face the day. So I also really appreciate that last point that may be important to highlight for our audience, that there are extended release melatonin formulations that have been really helpful for a lot of individuals in our community. And just the robust response of many individuals with Rett to trazodone for sleep maintenance, because there's such almost a joke that's not funny within the Rett caregiver community of Rett parties, these 2, 3 a.m. up and clapping and stimming and doing and waking siblings in the whole house. So I appreciate kind of having the slide to kind of distill out some of those frequent um, concerns that get brought up. And then actually thinking about one of the newer um, tools in our toolbox for individuals with Rett, trofinetide being FDA approved last year in March 2023, the only FDA approved treatment for Rett syndrome. So, um, as you know, we'll mention it's an oral solution approved for adult and pediatric patient age 2 and older, dosed twice daily. It's weight based and given orally or via G tube. The major warnings have to do with diarrhea and vomiting, which can result in weight loss, and then additional notes with strawberry allergy, renal impairment. And when we talk about adverse effects, the most common is diarrhea, and the vast majority of people will experience that, as we have experienced with our patients, vomiting, and then there's certainly some comments about fever, seizure, and anxiety. And this slide, I think, is helpful to talk about Dr. Marsh's group, who wrote kind of an expert opinion paper about how to approach planning for diarrhea management when starting trofinetide. And the recommendation here is about taking a 7-day diary prior to starting, then stopping all constipation related meds when starting trofinetide. And then looking, and this is another one, looking at all liquid meds that might contain sugar alcohols, and converting them to pill form, and starting a fiber, which can kind of normalize and bulk the stool, and then starting medications as soon as at the onset of diarrhea if needed, and then having diarrhea, if diarrhea happens, having families call the provider immediately rather than wait and suffer through it, like really aggressively reacting to those first loose stools. And then in this slide, kind of the thinking about outcomes in the LILAC-2 study results, looking at the mean Rett Syndrome Behavioral Questionnaire, and the Clinical Global Impression of Improvement scores in age range bars. You can kind of see the overall positive effect in both. I think the CGI-I is a little bit more obvious when we look at it. And again, the CGI-I is just kind of that, physician assessment of like how overall improved is the individual. Any thoughts that you want to add on this slide yourself as you're thinking about it?
I think the one thing I'd like to highlight there is that the top age is 22. And in the studies that were done, and I was one of the PIs as well, they were limited from the older patients. We know that patients can live a long time because there was some thought that after age 20, some of the patients dropped out of school in regular services and IEPs in schools. So they didn't want to confound variables of a time when therapy was taken away. If they might have gotten kind of worse because they weren't maintaining the therapy. So this goes up to 22, but we do treat patients older than 22 with trofinetide.
I appreciate that. And then it's important to mention trofinetide could be considered for any patient with classic or atypical Rett syndrome aged greater than 2 years. It might be of limited benefit in the mildest patients, and it wouldn't be recommended for patients with moderate to severe renal impairment, patients for whom dehydration or weight loss accompanying diarrhea would pose serious health risk, or patients for whom aspiration associated with emesis is very possible. Tim, what are some of the therapies in the pipeline or clinical trials for Rett?
Yeah, I think there's a lot of, like a lot of rare diseases, there's a lot of gene therapies being developed, and this is episomal transfer, not gene editing. It's a big discussion we could talk about. There's a couple different products. There's TSHA and NGN. The challenge with Rett is that we want to make enough protein, but too much protein is toxic. So we have to give a gene therapy that allows to make the protein, but not so much that it becomes toxic, as we see in MECP2 gene duplications in males sometimes. But that's a bigger discussion than we can have today. But there's a lot of hope. And just this week, NGN, the company that produces that, sort of presented some of their interim data. So it's very promising for the future, but it's always hard to know when that future will be here exactly. And so I think this is a very quickly tour de force discussion about Rett overall. But if we can go to the next slide, please, if that's okay. I also highlight a couple more things too, if that's okay. But I think Rett is typically a neurodevelopmental disease that causes regression early in life and it affects the individual for a lifetime. And it's caused usually by mutations in MECP2 in about 95% of the cases. That we have, because it is progressive, it's critical that the patients receive the care they need long term, whether it's neurologists, sleep docs, orthopedists. The current management, the only disease modifying therapy we have right now is trofinetide, or DAYBUE, also called that. It is quite helpful, but it requires some thought about managing some of the diarrhea as the main side effect to help with that. And every patient's response has been somewhat different in different ways. There's a lot of hope for the future in regard to some of the gene therapies that exist and that are out there as well. It's always hard to know what that means in real time for when they will come online, or if the data supports it as the studies go on, but we're very hopeful. And with that, I think that's a really quick and deep kind of dive into MECP2 gene mutations, Rett. And I want to say that the trofinetide is used for Rett syndrome. You don't have to have a gene mutation for that either. So that makes it kind of a unique situation as well. But Dallas, anything you want to add before we end here? Because this has been a great discussion. I really appreciate your mind and thoughts as well, too.
Yeah, thanks so much. It was lovely.
Cool. Well, I thank everybody for participating in this activity. Hopefully, this has been informative and been useful for the use of DAYBUE and trofinetide, and also the hope for the future for some of the gene therapies that are coming out. So thank you, everybody, for coming. I appreciate your time.